So thanks to Marie-Angèle Morel, I've been updated on your new position. Now you're an established professor of interventional medicine and innovation at the University of Galway in Ireland. You still carry the title of Emeritus Professor of Medicine at the Cardiocentro, Erasmus University, where I had the big privilege to get to know you many years ago, first as a PhD student, then as a colleague of yours. You have been my promoter for my PhD, as discussed. Now I realize that I am in an extremely good company, because the number is 104. You shaped the past, the present, and I'm sure you will keep shaping the future of cardiology in the upcoming years. I did an updated PubMed to look into Serruys PW, and I discovered the number of 2,751. So it's an incredible number. And I guess this is only you. It's not the person carrying your name. Your current age index in Scopus is 202, but I would like to give you the word by saying that nobody has ever shaped my imagination and has steered my willingness to do research in the entire world as you did, Patrick. So for us, it's a huge privilege to host you here virtually in Lugano, and I hope there will be an opportunity for you to come over and be with us a few days. Thank you, Patrick.
Sure. Thank you very much for this very, very kind word, and I'll try to stimulate your colleague by this talk, which is coronary revascularization 2040. You know, I start my philosophy together with medicine, so this is one of my favorite philosopher, Søren Kierkegaard, Danish, who said life can only be understood backwards, but it must be lived forward. So let's try to do that today. You know, about prediction, 𝐂𝐎𝐿 that's an American baseball manager, very famous in the United States, almost like Trump, who used to say, never make prediction, especially about the future. I like that very much. And at the ESC 2000 for the 𝐂𝐎𝐑𝐘 lecture, I had to speculate on the return of Andreas, if Andreas came back. At the ESC 2022, together with Jean Braunwald, I had to predict the CAD treatment in 2033. I was already paralyzed by the title imposed by the ESC. But at the ESC 2024, I had to predict coronary revascularization 2040, a topic imposed by the ESC. So I've given some thought about this topic. I'm not afraid of making predictions, since I used to tell my fellow, if the future is unrealistic, it will remain the future. If the future is realistic, it will be soon the past. Thereby, I don't take the blame of making a wrong prediction. Now, what is going to impact coronary revascularization in the next 15 years? I have to tell your young colleague, omics, genomics, lipidemics, proteomics. Today, we have already a nice paper on polygenic clustering, and AI will help to detect CAD, predict prognosis, and personalize the treatment. Combined with the non-invasive imaging, together with Jean Braunwald, after a few glasses of wine, we call that the imagomics. It has been changed now in imagenomics, but I like the imagomics. That will help us to document CAD anatomically and functionally, to allow decision-making between conventional revascularization, PCI, and CABG, and what I call pharmacological revascularization through plaque regression and improvement of FFR-CT. In the EVAPORATE trial from Matt Budoff, we see in 18 months with 𝐂𝐎𝐿 et al., we see the improvement of the FFR-CT. And it's clear that symptomatic, biological, and gene editing will boost the pharmacological revascularization. So your young colleague has to think that the rate of mechanical revascularization may diminish, at least in the young patient, if you use silencing microRNA against LPA and PCSK9, mAb against PCSK9, interleukin-1 alpha, 1/6, gene editing against PCSK9. We can talk about that in the discussion, and obesity drug. All that will boost the pharmacological revascularization. This is a good example published recently by one of my friends, Japanese. It's a 51 years old male, initially 240 LDL, rosuvastatin 20 milligram and 10 milligram of ezetimibe. He went down to 85, but look in the main stem, you have this napkin ring here, and over the next 18 months, the lumen was not further reduced, maybe a little bit enlarged, and the napkin ring became calcified. That's a good development. And if you look at the functional aspect, they had PCSK9 to the treatment. So the LDL went through 21, 14, and 10. And then what is good is that the FFRCT went from 77 to 80 to 84. That's what I call pharmacological revascularization. Now, I have to tell you, over the last 10 years, we have seen a decrease in the PCI and KBG market, and the trend will continue. I have to warn your young interventional colleague. This is an academic and industrial projection of the global PCI market. You could see that it will go down from 2029. And in dark blue, you have the deaths. In light blue, you have the DCB, and the DCB is going to increase, but the global number of PCI will decrease. Now, the age pyramid will have major various and evolving impact on the revascularization rate in the different regions of the world. It's clear that if you have non-calcified plaque with flow limitation, a young patient with soft focal lipidic content, it could be treated through plaque regression obtained with an anti-atherogenic agent, especially if you identify this patient by omics. So in young patients, mechanical revascularization will diminish over time. But in our society, what is increasing all the time is the patient above 70, 80, 90. So in these elderly patients with calcified plaque, impervious to regression, to pharma regression, calcium must be broken. Cutting, scoring, non-compliant balloon, atherectomy, lithotripsy, laser will prevail, and mechanical revascularization will remain predominant over time until my generation has disappeared. So in the 90s, the motto of Martin Leon was "Stand them all." However, the metal-less era has started, and in 2040, the armamentarium will be a blend, not an hybrid, a blend of various technological strategies. We had in the hype of the drug-coating balloon, but the drug-eluting balloon is coming back. We have the high-pressure balloon, the cutting, the scoring. You have the directional, rotational, orbital atherectomy. You have the laser. You have the lithotripsy. I'm very impressed by the stent, half metal and half biodegradable. The biodegradable scaffold is coming back, as well as the stent in iron, the stent in magnesium. You will see we are working on bioresorbable scaffold with fibrillate, supramolecule, or polylactide. And with a good friend in the United States, we are working very much on polylamellar polylactide scaffold. So the sky is the limit. Now, over the next 15 years, how will evolve the debate between vulnerable plaque and vulnerable patient? how will evolve the debate between systemic pharmacological of local device treatment. It's a ménage à trois, and I don't know where it's going to go. Will angina be perceived as less detrimental in terms of prognosis? That's the British vision, I would say, ischemia trials, 𝐂𝐎𝐑𝐘 2, and therefore be less aggressively treated by mechanical revascularization. Are we going to embrace the Lens-Gould view? Will bad physiology be perceived as more detrimental in terms of prognosis and be treated more aggressively by either pharmacological or mechanical revascularization? Or will plaque burden and high-risk lesion become the predominant factor in vital prognosis? That's the new vision of 𝐂𝐎𝐑𝐘 consensus and the what I call 𝐒𝐕𝐀𝐒𝐂𝐔𝐋, and I will come back on that. But already in the Emerald 1, there was 10 parameters identified on multi-slide CT scan indicating a lesion at high risk. So vulnerable patient and systemic pharma treatment versus vulnerable plaque and focal device treatment, that's the never-ending debate. Marco will remember the secret study with Joanna, which was the first treatment on the non-flow limiting lesion. That's 20 years of trial on vulnerability, and the last one is prevent, which is quite provocative, but that debate will be pursued. Now, what is disturbing and maybe coming back is the combined CCTA and PET, which on top of flow limiting of high-risk lesion may ascertain the metabolic activity of flow or non-flow limiting lesion. But this potent prognostic tool requires a cyclotron, but it's becoming less expensive and more easy. And you see here mixed calcified plaque in virtual reality in CCS, but you could see that there is some intense metabolic activity detected by the 18-fluoride CTA. Now, I mentioned the 𝐒𝐕𝐀𝐒𝐿. The 𝐒𝐕𝐀𝐿 stands for Artificial Intelligence for Quantitative Coronary Plaque and Hemodynamic Assessment. That's a consensus term adopted by HeartFlow, Cleerly, and Elucid. That's the three company FDA approved and will become omnipresent. So in the Emerald 2, which is coming from Korea, they use the cluster statistic and then identify clearly 5 features for identification of ACS and culprit lesion. One is the delta FFR CT across the lesion, the plaque burden, the total plaque volume, the low attenuation plaque volume, and the average percent total myocardial blood flow. You will see I'm coming with that together with HeartFlow, but it will be probably only available in the last quarter of 2025 of 2026. In 2040, all field of cardiology will have been pervaded by artificial intelligence. Please keep working on that, the young people, because that will render your operational task easier, will provide more quality time to the physician, and give back a more human face to medicine for the well-being of the patient. And look at all the field has been invited by AI. Now, the next slide is a listing of algorithm of machine learning AI for probabilistic prediction, and it's continued to grow as mushroom. It's unbelievable. In Galway, we use lasso regression, which is not new. We use the random forest and the extreme gradient boosting, but you could do to all the type of machine learning, supervised, unsupervised, dimensional reduction, reinforcement learning, etc., etc. That will continue. In 2040, the next generation of cardiac MRI will become more and more like CT, and the next CT generation will become more and more like MRI. Let's explain that. Today, 30 minutes of MRI give you stress perfusion, cardiac function, and infarct area. But in 2040, I'm sure that MRI will provide reliably coronary anatomy. This is unbelievable. This is a pictures of August 2000 by Kuhn Niemann showing the coronary angiography and the MRI at that time, but it was not always reliable. I think that in 2040, with AI, we will no longer record pressure invasively. Today, with non-invasive MRI combined with non-invasive pressure, we can have pressure volume loop, and in Galway, we use that intensively pre-intervention and post-intervention. Basically, instead of using focal pressure recording, we are looking at the streamline and vector of velocity. And we have a good consortium of Galway, Toronto, Melbourne, and CEDA SAING, and using AI automated algorithm, we use multi-slide CT scan, and we are able to quantify the aortic regurgitation post-TAVR with multi-slide CT scan. And you see, we use the same principle of streamline and vector of velocity to see where is the flow and how is the pressure involved. This is something specially for Marco. And let's shift gear. In 2040, we will have a new way to think platelet inhibition. I'm very excited about that. We will have metallic and polymeric device semi-covalently coated with biomimetic CD31. In a nutshell, CD31 is a trans-homophilic for endothelial cell. Endothelial cell attract endothelial cells, and trans-homophobic for platelet and leukocyte. You see all the device who can be coated by a CD31. Basically, it's a domain 20 amino acid. Okay, we can graft that to the metal and have on any implant. And basically, the CD31 technology provide a camouflage layer that mimic an healthy endothelium and bluffing the platelet and the leukocyte. So when you have the CD31 on a surface, the platelet are coming, recognize the CD31 and say, I have no job to do here. I have an healthy endothelium. I don't have to use the platelet and the leukocyte to block the bleeding or to block or to do the cleaning of the inflammation. We have made progress, and we have a lot of animal work in progress. This is a classical reaction on the stent struts, attracting a leukocyte and a platelet. And this is some of the preclinical work that we have done in the United States, in Poland, and in Paris. We show complete endothelialization in 7 days without the presence of thrombus. I don't have the time to show more than that, but we can have a specific lectures in the future on CD31, because in 2040, it will be amazing if P2Y12 and other anticoagulants might have become obsolete post-device implantation, not for the whole body, but post-device implantation. And you can see, remember that name, Giuseppina Caligiuri, sounds very Italian to me, but she is French, and she is the research of the INSERM in Paris, and we are working with her on that topic in Bichat. Now let's shift gears again, and what about acute MI? In 2040, after IC and intravenous thrombolysis, and I was part of that generation with streptokinase IC, after PCI post-thrombolysis, we were part of it in the thorax center. And after primary PCI, are we going back to IV thrombolysis with nanotechnology? You can see here a cluster of nanosphere sensitive to low shear stress, triggering release of nanosphere loaded with TPA with 100 of the usual dose of TPA. You see all these small nanosphere digesting the thrombus. And you know, my usual source of prediction is science. That's where I discovered many years ago iridium and do all these trials with iridium. Shear activate nanotherapy, SANS, of local drug delivery targeting thrombosed blood vessel with total or subtotal occlusion could be initiated on-site at home without risk of bleeding because it's 100 of the usual dose of TPA. Very exciting. I'm curious to see when it's going to come in clinical practice. Now, in 2040, conventional invasive coronary angiography as diagnostic tool will have left the scene. But today, how do we do the triage of the CAD? We start to use more and more in Galway the AI remote analysis. Then we have the pretest probability, which is recommended by the ESC, multi-slide CT scan for assessment of luminogram, vessel wall composition, and hemodynamics. That's what I call the one-stop shop, and I described that 2 times in the state of the heart. So basically, with the one-stop shop, you can have CT angiography for stenosis detection. You can have ejection fraction. You can have wall motion. You can have the resistance of the epicardial conductance vessel with fractional flow ratio, FFR-CT. You can have the microvascular circulation and myocardial aneurysm. That's the new parameter that we have developed with HeartFlow, which is going to be commercially available very soon. It's called LV% myo. And we have done a lot of hologram for the surgeon measuring the graft length. So what is today some practice in the top medical center will become really practice in 2040. Now, the conventional CT already today can give you tissue composition, lipid-rich area, fibrofatty, calcium, and so on. But we work more and more with the photo counting, which provide a new phenotype plaque. This is a publication just 2 weeks ago from our group showing something that I've never seen before. That's the donut phenotype of plaque. You see the calcium here surrounding an area of low attenuation. Amazing. Here's the lumen field by the contrast. And if you look at the histopathology, you see the deep calcium here, you see the necrotic core there, and you see the superficial calcium. And I almost forgot the inflamed perivascular fat, which is growing more and more as an important point. So today, clinicians start to use machine learning on their smartphone. We have that in Galway to predict MACE and death during the discussion with the surgeon. And when you have this one-stop shop, you can move directly to the interventional suite with a carefully planned coronary intervention based on pre-existing information. You can move directly to the operating room for a bypass surgery without conventional cine angiography, and you can have primary prevention starting. This is a case from PCR in Paris. As you could see, there is severe calcium at the end of the main stem, a little bit in the circumflex and more in the LAD. And what is the state of the heart in 2025 will be routine in 2040. So in this live case and out of the lab, we were planning the left main strategy based on diagnostic CCTA. First, we were selecting the guiding catheter after measurement of the sinus of Valsalva, diameter 2.28 centimeters. So we took an ABU band 3. Then we were selecting upfront the device. When I saw the calcium at the end of the main stem, I advised to use the lithotripsy upfront. So we did 10 activation of lithotripsy before implanting the stent. You can select the angiographic view for intubation of the left main. And you know, for the young fellow, to have a vision of the left main is very important. I have seen in my practice a young fellow killing a patient because he was intubating something which was an ostium of the left main. You can also, before the procedure, select the most angulated appearance of the left main bifurcation in the LAO 50 and caudal 35. You don't have to search for that. It's given before the procedure, before going to the cath lab. And you can, like we did in that case, select the stent length and diameter and the need for a pot 4.5 millimeter and use the planner software to predict the virtual treatment. You see everything is red here because we are far below 0.8, but the treatment predict that the proximal LAD will be 94, the mid LAD will be still in green, only the side branch of the diagonal will be in red. Virtual reality in the interventional suite is a reality. I love it. This is an analog OCT post-DCB that we have published 2 or 3 years ago. You could see the fractures and the dissection at the site of the DCB. You can merge the reality in the cath lab, and basically the hologram of the OCT post-DCB is hovering in front of the operator. You don't have to ask the clinician to move forward, backward, give me this vision. No, you do that with your sterile fingers in the lab because you see your colleague, but you see also this image also reacting on vocal order. So you can zoom on this dissection here. You can zoom on this dissection just by asking that. And then you can have a flying through of the same image if you want. On top of that, all the desired measurements are superimposed on the hologram. Now, something that is very important, young people, more and more, you will have to away from the radiation. I mean, with my good friend Eugenio Picano, who was in the 70s in the Thorax Center, we wrote this paper on cardiac radiation exposure and incident cancer challenge in opportunity. And we can do that. We can have what we call FORCE. FORCE is fiber optical real shape. They have already 1,100 patients treated with this type of technology. It's using light instead of X-ray to steer the guide wire. You see here the console. The console is connected to the table of the cath lab here on the side. And basically the guide wire contain optical fiber, and the light is moving very, in this guide wire, you have 4 microfiber. And if you bend the catheter, then the speed of the light in these microfiber change, and you have online, in real time, a three-dimensional pictures of the tip of your guide wire or the tip of your catheters. So, as I said, the speed of the light is amazing, so the light go to and through, and you could see your guide wire without fluoroscopy overlay to this multi-slide CT scan, and when you move your guide wire, you can see where it's doing, and you can also move the multi-slide CT scan and see the guiding catheter going on the guide wire. This is not science fiction. It is the reality because it has been used in more than 1,100 patients in the peripheral circulation. You see here, without using fluoroscopy, I'm bending the catheter, and immediately on the screen, without fluoroscopy, I see the position of the catheter. I can make a loop now, and you see immediately the loop on the screen. This is for the new generation. Stay away from the radiation. In 2005, Marco can tell you, I installed a robotic magnetic cath lab. I was crazy about this technology. It was probably too early for the robotic, but nevertheless, we did it. In 2040, young cardiologists will no longer be exposed to X-ray beam and orthopedic damage and will play a video game in the interventional suite. You can see the magnet, which is rotating in two directions and moving the tip of the catheter, which has a magnet at the tip of the catheter. And the first-in-man experience of robotic assist transcatheter edge-to-edge repair has been done. But what is much more interesting is what the surgeons are doing. And in Riyadh, I had the privilege to see the first robotic human heart transplant in Riyadh. And you see the surgeon is cutting the pulmonary artery, cutting the aorta, cutting the right atrium, cutting the left atrium, and at the end, you see the mitral valve here, and then he can pull out the worn-out catheter out of the cavity of the heart, and then in the next sequence, he's putting the new heart in the cavity, and again, attaching the pulmonary artery, the aorta, the right atrium, and the left atrium, and all that by a small intercostal incision of 7 millimeters. Now, let's go back to the one-stop shop and moving directly to the operative room. What was a first-in-man pilot study in 2024 that we published in the European Heart Journal will be routine in 2040. This is the paper, Coronary Bypass Surgery Guide by Computed Tomography, only guide by computed tomography. You see we did that in 114 patients. The feasibility to do bypass surgery without cine angiography was 99.1%. The patency of all the anastomose control at 30 days was 92.6%. And you see the agreement between ICA, conventional angiography, and CCTA was 83%. So I can tell you, I'm sure that in 2040, conventional coronary angiography prior to CABG will no longer be performed. With the sole guidance of new generation of CCTA, decision-making in favor of surgery, PCI, or pharma will be made routinely by the heart team. And CCTA, as a game changer, may change the gatekeeper of the mechanical revascularization. That's probably the most important statement. Interventional cardiology, if they want to stay in the game, has to learn how to do multi-slide CT scan and master the field and do the indication on the things. So what was a first in man at that time? will become reality. You see here heart team, new style in Galway. You have the virtual reality hovering over the table. The surgeon can show with his fingers what he wants to do, but at the same time, he can see us in the operative room or in the heart team. And here I'm measuring with the Google on my head and measuring the length of the bypass that has to be harvested by the surgeon. And you could see we did that intensively for John Puskas in Mount Sinai. He loved that things. You see John Puskas and Yagat Nagula. He did, usually he does 5 arterial anastomoses. The Lima, that's the cartoon he's sending to us. I want to do a Lima on the LAD. On the side of the Lima, I want to do a radial going to the obtuse marginal. I want to prolong the height by radial artery. So all to create the Lima by the right artery. So altogether it's 5 arterial anastomoses and all that of pump. And as you could see, after the procedure, he's systematically measuring the flow in all these vessels. One of the best surgeons for coronary artery in the world. And we control all his work by multi-slice CT scan 30 days after the procedure. You could see indeed the radial attached to the Lima, and you could see the Lima prolonged by the radial artery here. But not everybody can make 5 arterial anastomoses. So we have been working on biorestorative, biodegradable graft. That has been published in translational JACC and right now, a few weeks ago, with Renu Vermani. So coronary bypass graft made of electrospun fibrillated microfiber of biodegradable supramolecule, which could be available on the shelf in the operative room and will eliminate the cut in the legs of the patient to find a saphenous vein graft. You see here the matrix of the microfiber with the nitinol in. You see the biodegradation process. Here you see in scanning electron microscopy the nucleus, and then if you look carefully, there is the connection between the cell. I made a cartoon of it. We can also see in transmission electron microscopy, but all these cells are von Willebrand, CD31, and have connexins. So it's really pretty good. You see the evolution in 12 months. And then this is a multi-slide CT scan in the sheep model, connecting the bypass graft to the LAD, which has been ligated here. And this is not only theoretical. We have done the first in man. You see the bypass graft going to the trifurcation between the right coronary artery, which is totally occluded, the PD, and the posterolateral work. So in 2040, the cardiovascular surgeons are still alive and kicking. I was very impressed by the genetically modified porcine to human cardiac xenotransplantation. Gene Braunwald said that the date of the first pig to human heart would prove as important as date of the first human cardiac allotransplant in 1967. I was 20 years old at that time. And the question is, what will prevail, the xenotransplantation or the artificial heart? I met not so long ago Alain Carpentier. He's an old man now, but the Carmat heart is a mixing of Carpentier and Matra, Matra being the company doing cars and airplane. So 22 years after the introduction of stem cell in clinical trial, we published that in JACC 2002 with Peter Smith, we are still dreaming of biofabrication, recreating the heart helicoidal structures. That's again a publication of science. What you see is fiber deposition by jet spinning onto a rotating ventricle-shaped collectors, okay? And then you have the X-ray micro CT to prove that you have created an helically aligned fiber scaffold. And then you have the seeding of the scaffold with human-induced pluripotent stem cell-derived cardiomyocyte. And then it's amazing, absolutely amazing. 5 days after the initial cultures, these ventricle scaffold seeded show spontaneous contraction. And you can judge the difference between what Mother Nature does, an helical type of contraction, versus a circumferential type of contraction. Now, almost the end, photo counting. Photo counting will eliminate the conventional invasive coronary angiography as diagnostic tool and will accelerate that process. I thought it would take years or decades, but I think it will go fast. Why? Because there are about 300 hospitals around the world which has the photo counting. And like the drug-eluting stent in 2000, I can say that's the next tsunami in cardiology, and it is on the horizon. Here you see a conventional CT. You will agree that there is some blooming effect of the calcium here, and you will agree that the low attenuation area is quite unsharp. They try by post-processing to improve that. They improve somewhat the calcification contours, but you agree that the low attenuation area, probably much more important, has basically disappeared. And then you see the photo counting, the calcium is very sharp, and the low attenuation is also very sharp. So I don't know what kind of high risk is this type of lesion. This is conventional CT after stenting. It's blur. But now with the photo counting and the resolution of 111 micron is crystal clear what you have. It's so clear that you can do a 3D reconstruction of 2 stents in the same vessel for a bifurcation. You can appreciate the metallic carina that you see here. Quantification became very reliable. This is a cross-section. You can see it's easy to measure the millimeter square, and it's also easy to measure the diameter stenosis at that site. It became very easy. And this is a case where photo counting can identify a complex calcified plaque morphology even better than the intravascular imaging. You see the lumen field by contrast, you see the superficial and the luminal calcium, you see the deep calcium, and something I've never seen before because we could not see with the usual imaging is the interconnection between the deep calcium and the superficial calcium. You know that IVUS show only the superficial calcium while shadowing the deep calcium. Now let's look at the total occlusion that will help us. This image will help us. First, soft proximal cap, a little bit calcium here. You can perforate that quite easily with or stiff guide wire. Then very low attenuation, probably something thrombotic here. Then low attenuation, but will be soft, could be crossed quite easily. And fortunately, there is no calcium in the distal cap. So the conclusion is piece of cake for recanalization. And this is again this image that we just published. And as you could see, we have an intense relationship with Filippo Cademartiri that you certainly know. And you have seen already that donut picture that we just published. But I insist again that the superficial calcium and the deep calcium and the necrotic core in between can need to be seen by the IVUS because you have the shadowing of the deep calcium. And the near spectroscopy can detect the lipid, but cannot detect the depth of the plaque, and that remains unknown. I'm finishing by 4 slides, which is quite amazing. That's beyond the tidal wave of the photo counting detectors. Let's have a glimpse into the future with the so-called hierarchical phase contrast tomography, HIP-CT, going from macroscopic volume rendering to microscopic morphology. So in 2040, we could have a resolution of 20 micron per voxel and ultimately a resolution of 2.3 micron per voxel. This is a paper that has been published. 𝐂𝐎𝐑𝐘 is working with us. He was very privileged to be part of it. And what you're going to see is a lady, 87 years old, with a stent in the LAD, an inferior MI, dilatation of the mitral annulus. And let us look at a volume rendering. Here is the volume rendering, the fat surrounding the heart. We go through, and you could see clearly 2 things, not only the artery, but the vein. You can see the secondary, the tertiary, the quaternary vessel, and then something that I never realized is that the coronary artery can be shift away from the myocardium by the fat. And you could see all these small vessels, pre-arterial and arterial, plunging literally into the myocardium. That's not my vision of microcirculation, and certainly it raises a new concept about can the fat surrounding the heart impede the microcirculation. Not only you could see the coronary artery, but you can also go through the myocardium. And if I stop here, is because it's black, and black means subendocardial infarct of sclerosis. And you can investigate all the valve. You could see clearly the papillary muscle and all the chordae, big and small, and the connection with the valve. I don't have the time to describe the enlargement of the annulus, but you have a clear idea of what this technology can offer. Now, let's have one slide about this lady. Here is the stent with the calcium in the LAD. We are doing one cross-section of the RCA. And then with a voxel resolution of 20 micron, you see the adipose tissue. You see the adventitia, the media, the lumen, and here in this red frame, you have 2 nodules of calcium. That's now a voxel of 2.26 micron. And you can see that they have this kind of speculated appearance. Then these atheroma, the media, and the vasa vasorum. So one of the last questions for the future is which modality of imaging, for example, the non-invasive hierarchical contrast computed tomography on the left-hand side, or Gary Turney with the intravascular micro-optical coherence tomography, which is coming. It will be there very soon. This is already pictures of vulnerable plaque published by Gary Turney. The lumen is here. This is the cap, yeah? You can really measure that in micron, the cap. Behind the cap, you have this nasty crystal of cholesterol, and then you have the necrotic core here. And in another view, you can see leukocyte tethered to the endothelium. I don't have to describe here, I've already described, but one of the key questions, will the non-invasive imaging ever supersede intravascular imaging. And I didn't talk about the spectral analysis, or at least compete with it. Now it's time to conclude and tell the truth, all the truth, but the truth. I misled the audience only on this last topic of the 𝐂𝐻𝐑, and I must confess that what you have seen is a post-mortem heart fixed in glutaraldehyde, but it's already an extraordinary instrument for the anatomopathologist who doesn't have to cut through the heart to get all this information. It was done in Grenoble in the European synchrotron radiation facility. The impinging photon is accelerated linearly by a synchrotron. Here is the container with the heart rotating. We are rotating the container, and there is 177 meters between the synchrotron and the heart. So instead of rotating the beam, we have to rotate the heart. I have to conclude. I have to give a take-home message. I don't have a take-home message, but I used to say to the fellow in the department, if the future is unrealistic, fortunately, it will remain the future. And in my career, that's about 40 years, or even more than 40 years, I've seen that many times. What seems unrealistic today will be the future. And the second point for the young people, if the future is realistic, sadly enough, it will soon become the past. Everybody will do it. Thank you for your attention.
Patrick, thank you so much. It has been a very visionary talk, and we have really enjoyed it so much. Even more so seeing you back once more. Are there any comments or questions? Perhaps I can warm up the audience here by sharing with you that I was coming back from Chicago. I don't think you've been to Chicago. I did not meet you there. And so there was the 5 years follow-up of FAME3 study, which is a confirmation of what you, Patrick, published 10, 15 years ago, that the syntax score works. In the low syntax score, PCI did a better job for MACE without PVR. So it's 3-item MACE, death, MI, stroke, then surgery. In the intermediate arm, it was the opposite. In the high, it was an equipoise. Basically, the outcome was so bad that PCI was no better than CABG and vice versa. Now, the question comes now, why is the syntax score so forgotten in contemporary practice? And why have you not come up with an artificial intelligence automatic calculation of it? Because I think this is the only reason why the people are lazy enough not to calculate it.
You cannot hear Marie-Angèle, but she's laughing. She is laughing because I had a few success in my life, but that's one of the big failure. And I get close many, many times. I mean, when I was at the Imperial College, HeartFlow moved to London, and we had an office in London. That's 2016, and we used to go to London with Yoshi to work on the artificial intelligence on the multi-slide CT scan and have an automatic syntax score. And it works very well. I mean, this engineer within weeks has a perfect segmentation with an accuracy of 97%. And then we start to work on other characteristics, calcium and et cetera, et cetera. And then John Stephen, it's public domain, get some kind of brain tumor and left the field. And then they left London. Campbell Rogers became the successor, but he never embraced the concept of the syntax score. He believed that what is more interesting for HeartFlow is the base of the pyramid, you know, the rule out and the early stage of the disease. So recently, I start to work again with MEDIS and with GE to have these things completely automatic in quantitative angiography and in multi-slice CT scan. And I hope that, you know, resilience is something very important in your career for all the doctors. You had resilience, I have resilience. When we fail, we come back, and at some point, we win the battle. So I hope that at some point we will have that, because it's true. It's so simple, is that syntax score was created by Marie-Angèle and myself in 2005 in almost one single afternoon on a Saturday afternoon. It's not rocket science, but it's clear that the extension and the complexity of the lesion, and we could have a beautiful instrument today, but we have to convince the industry. And as I said, I'm working with GE now on that, and I hope that we will have that at some point. Story of a success and a failure. Yeah, you need
do you hear me? Thank you very much for your beautiful and visionary presentation. They're really incredible. I would say one probably of the best presentation we ever had at the Cardiocentro in the last 20 years. Really impressive. By the way, I remind very well your presentation. I remember very well your presentation in 2000, your prediction on Andreas Grünzing, and I think, if I remember well, you imagined Andreas Grünzing with the beard, as you look like. Just now a question concerning training of young doctors, of young interventionalists, that let's say also for electrophysiologists or for imager. You mentioned several skills that they need to have in the future, not any more manual skills, because when I was a young fellow by Bernie Meyer, just insisted you need just 2 neurons and good hands to be a good interventionalist. I think it's not anymore the case today. And you mentioned several skills, informatics, imaging, very well imaging knowledges, and which is in your mind? How do you imagine the training of young doctors, let's say in the coronary field?
Yeah, I mean, in the coronary field, I think that you have to keep in contact with what I would call the genetic and the genomic. I think really you have to understand the basic of these things, because you will have smart people telling you that that individual has such a proteomic and such a genomic and such a lipodemic, and therefore he will be a diabetic with atherosclerotic problem, etc., etc. So you have to understand that field, that you like it or you don't like it, because you will have people telling you these patients have these characteristics. The second, you have to quickly, and it's not difficult, to master the understanding of the image in multi-slice CT scan. All the fellows coming in Galway, they learn in 6-7 weeks and became expert in composition, anatomy, and flow. It's not difficult. You know, they are technicians to make the pictures. Our job is to understand the pictures, not to make them. So the relationship with the radiology is so important. We are all doctors. Of course, the radiologist is somebody who likes the pictures, like to look at the pictures in the morning, and doesn't take care of the patient. Either they are going to take care of the patient, but you know, after the war, they missed the point. I mean, the radiology of the heart became in the end of the cardiologists. They miss the echo. They didn't take the echo. Of course, in the multi-slice CT scan and the MRI, they were the master, but they were not treating the patient. Now, some of them has understood that they have to go into the field, and vice versa. The cardiologist has to go in the field. If you talk to Gianluca Pontone and Daniele Andreini, 2 of them were echocardiographists initially for many, many years. And at some point, somebody tell them multi-slice CT scan is the technique to come. And they went there and they were very, very successful because they are cardiologists treating the patient, not only making pictures, but treating the patient. And I don't know at what stage the radiologist will understand that or the cardiologist, but they have to work together. Marco knows that the great chance that I had is to have Pim de Feiter. Pim de Feiter was an extraordinary gentleman, very diplomatic, and he was in the interventional lab 100%, but he has also a share of professor in radiology, and he was able very early at the time of the magnetic room to have the flying through on the screen of the cath lab. It was too early. It was too early. I remember when I think that I present that at PCR in 2008, 2010, it was too early. But now it's really a reality. So when I say who is going to gatekeeper is a very important point, because imagine that the cardiologist downtown, that the internist downtown, that the GP downtown send patient with chest pain to the radiology, and that the radiology is smart enough to say that patient has to get PCI, that patient has to get bypass, that patient should be radial. That's a little bit what the young generation has to understand. So the treating physician, I'm talking about the treating physician. I'm not talking about the interventional cardiologist, because you may be somebody in primary prevention, but you have to pick up in the non-invasive imaging the patient who have already plaque, and make a good program for that patient based on your knowledge of lipid, of whatever. Don't forget that the young GI, after the Korean War, that's the moment the people discover that at 2022 you can have already plaque. Okay, so that's what we have to go in. I see Tiziano Mocetti, so I think our time is over.
We have still questions for you.
Yeah, I had a question, and I also have an observation about this last question. So you were discussing as if like in 5-10 years, there will still be a cardiologist or a radiologist sitting in front of the computer and evaluating the images and then choosing which interpretation we should give them. But don't you think that this role will be taken by artificial intelligence? All these images will be put into an artificial intelligence box, and this will tell us what we should do?
Yeah, I think you're right. As I said, in the book of 𝐂𝐕𝐀𝐿, he is describing that the American physician is spending 12 minutes per patient. And in these 12 minutes, 10 minutes, 2 minutes is high to high with the patient, and the rest is typing for the Obamacare all the information. That has to change. I think that today, every meeting in Galway is minutes artificial intelligence, all of them, okay? The machine learning is never tired. The glucose of the machine learning is always okay. And they have, and that's the most important, not psychological bias. If I let do the minutes by Marco or by myself, you will have different minutes because we have a bias in psychology. But the machine learning not. They report what you say, and they eliminate all the blah blah for the central point. So machine learning will be there. We should not be afraid of, because indeed the interpretation in radiology, but also in dermatology, is much better than the average doctors, because we get tired at the end of the day. You may have a bad night. You may have a psychological problem. So don't be afraid of the machine learning. Invest. Is that responding your question?
Yeah.
So thank you very much for the talk, very inspiring. I liked a lot your last question on the future becomes rapidly the past. In this respect, how important do you think is catching the right trajectory of the disease that can be based on epidemiological changes, lifestyle, climate change, and so on? And do you see AI-enabled epidemiological research as part of the future in our field?
I'm not so sure that I fully understand your question. If the question is, it's clear that in terms of research, I mean, what is research? Research for me has always been the future clinical care. That's how I see it, okay? Even if you go in something quite basic, I mean, I show you the nanosphere and the TPA and so, that's research, okay? That's published in Science. If you take science, you will probably understand 20% of what it is in science, okay? But there are the basic idea, and the time is the way is to implement that. That's what it is difficult. And you must have the gut to say, I'll do it, yeah? But research is so important. And I think that if you don't do research, you quickly fall into repetition of pushing a catheter in the patient, and you will have some kind of burnout or fatigue to do that. So research is really the way to keep the interest for the future. I mean, I'm sure that Marco has the same syndrome that I have. We need research to stay alive. I mean, to keep doing medicine. Otherwise, it became boring. I mean, many of the fellows who came to Rotterdam was in the 35, 40. They were in the critical moment in their career where they were repeating things every day without future. And it's only by exploring something outside the routine that you keep the interest for medicine, at least for me, and I'm sure for Marco.
Patrick, thank you so much. I think with these wonderful words, I think it's the moment is to close, to thank you once again deeply for your availability, for your mind, for the willingness to share a piece of your mind and your brain with us once again. And I would like to close with a big applause, but also by forcing you to promise that you would come over to Lugano, because I'm sure you will enjoy it. And here it's not raining like in Galway. So bring over Marie-Angèle Morel and the fellows, and we will have a wonderful weekend discussing about science. Thank you so much.
Yeah, bye-bye. Bye-bye.